Hello, everyone. I'm Michael Hodin, CEO of the Global Coalition on Aging, and we're delighted to be here for a panel discussion today on the very, very critical topic of aging and vision health, a topic that has been around for, of course, a long time, but becomes even more dramatic in a greater concern in the time of COVID-19 pandemic. I have with me three experts from different aspects of the field. And we're going to spend the next 30 or 40 minutes having a conversation around this topic that hopefully will be both educational and most importantly, provocative. Maybe we'll break a few eggs here and by virtue of that, engender progress in this very important space. So Jane Barratt, PhD, and Secretary General of the International Federation on Aging, a long friend. Thank you, Jane, so much for being here. Hello, Jane. How are you?
Good.
Bonnielin Swenor, Master of Public Health and PhD at Johns Hopkins, Associate Professor of Ophthalmology, Wilmer Eye Institute, Johns Hopkins University. Thank you, Bonnielin, for being with us. We're so delighted. Hello, Bonnie. How are you?
Thank you so much.
And Dr. James Tsai, MD and MBA. Jim, I know you're here in New York, where I am. You're at NYU, the Delafield Rogers Professor and Chair, Department of Ophthalmology, Icahn School of Medicine at Mount Sinai. So thank you so much. I know when I came to visit you the first time, I realized that I made a big mistake because I should have also asked for an appointment and get my vision checked, which I did not, but I got it afterwards. So great to see you. So let's jump in here. We're delighted from the Global Coalition on Aging point of view to have addressed this vision, health, and aging topic virtually from our beginning, roughly 10 years ago, in one way or another. The only thing that I think has been constant is that we've been collaborating and a partner with IFA, Jane, so thank you very much. And Jane, I remember when you were so kind and generous to invite us to one of your early think tanks. Of course, it was in the days when we could all get on a plane and travel. In Barcelona, it was great fun as well as learning a tremendous amount. And at the time, I remember it was one of the first events globally where we brought together multi-stakeholders, and you really got us at the intersection of aging and vision health. So maybe you could start by giving us a sense of where you've been in this journey, some of the key milestones, and how COVID-19 might be changing anything that we're doing. Thanks, Jane.
Yeah, look, thanks, Mike, and thanks for the opportunity to be with you today. Look, I'm not sure that IFA broke ground, but I think what we did was we started to understand the profound responsibility that an organisation in the field of ageing has in partnering with vision organisations and learning their craft. In many respects, it's not all about us. It's not all about ageing organisations. We have a profound responsibility to reach across the aisles and work with vision organisations. And if we don't do that, we're actually not going to get good policies. So if we look at what progress has been made, nothing's changed on the one hand for many people with vision complications. And on the other hand, everything has changed. So just this year at the 73rd World Health Assembly, it was an adoption of the resolution for integrated people-centred eye care, which included preventable blindness and impaired vision through the first World Report on Vision. This is the first time in history that a report showed the issue of blindness and vision impairment was a true global health problem needing urgent attention. It outlined that at least 2.2 billion people in the world are living with blindness or vision impairment, and at least 1 billion people are living with a condition that could have been prevented. And this intersection of prevention and treatment and screening is where we belong. Our three key areas that IFA works in, and I'm sure the Global Coalition, prevention, access, equity. So on the downside, population is actually colliding with the burgeoning epidemic of diabetes. And we know from IDF in 2019 that there's about 463 million adults, that have diabetes. And by 2045, this could be about 700 million. Why is this important? Because one of the complications of diabetes is diabetic eye disease. So the IFA back in 2017, in partnership with the International Agency for the Prevention of Blindness, as well as IDF and Bayer, conducted a 41-country study of over 7,000 people, those with diabetes and those providers. And 3 key areas came to the fore: patient education and empowerment, guidelines and protocols, and coordinated care. I won't labour on the facts and the results of the studies because I'd like to hear other people speak. But let me just, in the context of COVID, where are we at the moment? We know that ophthalmologists around the world are really trying to create a safe, protective environment for those people that need emergency treatment. But routine screening, routine treatments are really delayed. Now, we've got to layer that anxiety that patients have on top of the anxiety of COVID, and also the very confusing messages we're hearing from government and public health. Go into lockdown, don't go into lockdown. Put your mask on, don't put your mask on. And that's why the Vision Academy, that's comprising about 100 ophthalmologists, and I have the privilege of being at the Academy, has created and evidence-based guidelines. So it's about what happens in the clinic, what happens outside the clinic, and what happens with treatment. And so we do have evidence-based guidelines, and we will be living with COVID going forward. But I think it's also, Mike, opened up, and we say it, don't we? Crises open up opportunities. So we've actually seen new ways of anti-VEGF treatment processes going on. Some ophthalmologists have actually gone into people's homes in Israel. So there's lots of different telehealth and innovative solutions, artificial intelligence coming to the fore. It's about balancing, the patient safety and ensuring those that need treatment and screening get it, also with the safety of healthcare professionals. So have we made progress? Yes. Have we made enough? Never, because I'm very impatient. So I'll close it there, Mike, and hand it over to you.
Well, great. Thank you, Jane. And that's one of the reasons we love working with you and with IFA so much, because we too are not very patient. Although we recognize that we have made some progress, we're barely getting started. But one of the points you just made, and it's a great place to move to go over to Dr. Tsai, Jim, I hope we can call each other by first names, is on this issue of digital health and the relationship there. Because I remember when we first got together a couple of years ago, Jim, that was an area that you were doing a great deal of work in. But you're there at NYU, Mount Sinai, and is it Mount Sinai? Which is the?
It's New York Eye and Ear. New York Eye and Ear.
New York Eye and Ear. Yes, I realize now. So thank you for that clarification. You're there at New York Eye and Ear, and you're seeing patients. And we'd love to hear what your experience over the last few months has been. Also link it to where we need to be. At some point, we'll get through this pandemic. What are we learning from it? And some of the digital health tools, particularly, as Jane said, telehealth in the home. We all know that, the last great institutional advance in hospital care was a couple hundred years ago. So maybe now we do move to the 21st century. But Jim, give us a little bit of a feel where you are there, both with respect to your patients, how the practice is going, and some of your innovations on telehealth.
So COVID was quite challenging here in Manhattan, New York City. And as Jane pointed out, a crisis leads to opportunities. And so what we've done is we've had to fully embrace teleophthalmology. Oftentimes there was resistance, but I think COVID made it necessary to take care of our patients, especially when elective surgeries and elective visits were canceled or curtailed. But ophthalmology and vision, the eye exam, is very challenging to do via telemedicine. I'm a glaucoma specialist. So I think what it's spurred is interest in innovation on how do we check eye pressures in patients at home? What technologies are available? I just heard today that there are, attempts to do 3D printing of low-cost tonometers that can measure eye pressure through the eyelid. It's gotten us to understand that our patients are going to have to check their vision or do visual fields. What we recognized during the pandemic is that every potential idea needs to be weighed. Could it help? Because it's caused us to rethink how we take care of patients. As you know, social distancing is the current standard. And here at New York Eye and Ear, on our bicentennial, we've had to really decide how are we going to take care of patients in the 3rd century. So we've decided to totally change how we see retina patients. Retina patients used to come, wait long hours, wait for their exam, wait for their testing. What we do now is we will oftentimes offer retina patients to come in for their ophthalmic imaging test with a photographer, have them go home, and then we'll schedule a teleconsult visit with their retina specialist to review their images so that they don't have to wait around for hours and put themselves at increased risk of contracting COVID. We've also implemented at Mount Sinai Health System a teleconsult program for our emergency department at Mount Sinai West and Mount Sinai Morningside, because we recognize when patients come into the emergency department, oftentimes there's a lengthy wait for an ophthalmologist to come in. So now everything is done via teleconsults initially. And guess what? It's better for patient care. Patients wait now 15 to 20 minutes to get an ophthalmologist via teleconsult, where it used to take oftentimes hours for an ophthalmologist to come in for in-person visits. So we're going to have to really embrace artificial intelligence and telemedicine to really change how we deliver care. Now, the final point I want to make is this movement to telemedicine has also heightened or highlighted the inequities in technology access for our vulnerable patients, and also the challenges of really educating all patients about technology. Some of them are more tech savvy than others. So I think there's going to need to be education on how do we provide our citizens with the best technology and best technological education so they can access telemedicine if the circumstances call for that.
Great, well, thank you. And in fact, we were just on some calls earlier this morning. You mentioned glaucoma, other areas as well. You know about diabetes challenges, Jane, that you mentioned. Age-related macular degeneration is yet another. And so many of these, which are problems, I think we're finding innovative ways, even in a couple months, how to leverage the telehealth and telemedicine and AI opportunities. Bonnie, thank you again, and it's nice to see you. At Johns Hopkins, and on behalf of the rest of us in the world, want to also thank your institution for all the amazing public health work that you are doing and helping us through this pandemic. But Bonnie, one of the things we've talked about quite a bit is the way in which aging itself, or the perceptions of age, become an effective barrier around vision. Jane, we've worked in this space in many different places where ageism is not only a cultural barrier to full engagement, but even in healthcare. Well, she's 82, and that's what happens when you become 82. Your vision starts to, no, yes, macular degeneration or a cataract or something. So tell us a little bit about that, what your background has been on it, and again, whether there's been any heightening of this in the COVID period when older adults are clearly more at risk?
Yeah, no, thank you. I think this is critical, and as you're indicating, in my viewpoint, been elevated at this time. So, I think that there's been an important and overdue shift to a more holistic view of the place of vision and eye health in the broader picture of health and aging. And that movement, from my vantage point, really has three key components. Education is key, and is key in continuing that process. And we have to continue educate older adults, family members, the public about the value of vision, about the importance of caring for vision and eye health, but also providers outside of ophthalmology about thinking about vision as part of the whole picture of health. Policy certainly is also important, thinking about ensuring that vision and eye health is integrated into either universal health care coverage, or here in the US is broader expansions of Medicare coverage, to make sure that people have the access and opportunity to get to eye care services that they need. That's critical. And then as a researcher, I certainly think a lot about the research component. As Jane indicated, I've been grateful for, over my career, the enhanced collaboration across many areas of research, specifically aging and ophthalmology, to better integrate. And that's been critical and remains critical in this mission to ensure that vision and eye health are embedded in this broader picture. But beyond that, I think that there needs to be a continued momentum, and I think this time of COVID is elevating this need to do more and to think more equitably, again, I think as Jane indicated, about the value of vision and the impact of vision loss on people's lives. Jane discussed this movement and this increased discussion around person-centered eye care, that's what it's all about. It's ensuring that people are at the center of this process. And that's, I say people very broadly, right? People from all communities, as well as making sure people with vision loss, or the stakeholders involved, older adults, are driving the research, the education, and the policy that's being pushed forward. On top of that, what I hope that we move forward with is not just thinking about prevention and treatment, which are critical, and we can never lose sight of that, but also understanding what impact vision has on the trajectory of health and the ways in which vision loss can change that. I think that there's been long a myopic view, to use an ophthalmology term, on how vision affects health. A lot of the work has been cross-sectional or very short-term, and we need to take a longer focus on that. We need to understand the impact of vision and vision impairment on someone's life today, tomorrow, in 10 years, in 20 years, and in 3 decades. And once we have a better understanding, to develop better strategies to help people with vision loss age well and be healthy. Yeah. Because it's really unrealistic from my perspective to think that we're going to cure, prevent, and treat every single cause of vision loss and blindness in our lifetime, and probably in my kids' lifetime. And so what does that then mean for those who have vision impairment or will become visually impaired? I think we need to invest time and focus and resources into ensuring that those individuals can age well. And this time of COVID has elevated this question of equity. And in my mind, that is a question of equity.
Very well said, and thank you. And we are, particularly here in America, the questions around equity, the pandemic, healthier aging, as I mentioned, and of course, Jane and IFA and the Global Coalition on Aging are working together with the WHO and the United Nations on the Decade of Healthy Aging. Bonnie, you alluded to all of the needs around this cultural challenge of ageism. So I'd like to come back and, first of all, to say to the 4 of us here, please feel free, each of you, to jump in I think, we can manage ourselves, so please jump in and ask each other questions as well. But I will continue in the absence of that. And Jane, I'd like to come back to a point you made. You talked about the 40 countries that you've worked in, the analysis.
Sure.
Sorry.
Go ahead.
Well, I was just going to say, the Global Coalition on Aging is, as I think you know, right in the middle of an international vision health scorecard which we're working on, and we've got about, I don't know, somewhere like 15 countries, and many of the in the United States, many of the Europeans, Australia, China, Nigeria, Saudi Arabia. So it is global, although it's not everywhere. But as we think of that kind of scorecard and we look at the 40 that you mentioned, are there places, here we are at the Geriatric Society of America annual scientific conference. I think there are thousands who are joining, upwards of 5,000 or more. Maybe it's many more now that it's virtual. It is US focused, although it is global. So Jane, from your point of view, where ought we look for some of the best practices? What are some of the lessons over time and even now in COVID that you're observing?
Look, it's a tricky question, Mike, because what you're asking me to do is compare apples and pears, because every country's got different systems and different regulatory frameworks. And so, the question is, we can't do a comparative analysis. We've actually got to dive deep into, the barriers within country. And sometimes it's barriers within the country, province to province or state to state. But I did want to pick up on a couple of points that Bonnie made and also James, if I could. And just the unique interconnection of vision, hearing and cognition, that really is saying something about dementia. And I don't think that we make that connection well enough. And this is the future. We do know how to prevent dementia, some kinds of dementia. And so this connection between vision, hearing and cognition, vitally important, in terms of also mental health. So that's one bucket that I think we should be moving into. And I'd be really keen to hear James's thoughts about, vision being the window to the soul and end organ damage, because vision complications really do give ophthalmologists an insight into what's happening with end organ damage, because in the context of how IFA thinks and works, it's about function. It's not about DME or DR or glaucoma. It's what is the functional impact and therein the economic impact, because we've got those two. So I'll be quiet and I'd be fascinated to hear, perspectives from colleagues.
Go ahead, Jim.
Well, I think, Jane, you've hit it right on the head of the nail. In terms of ophthalmology is really going to take even a more leadership role in giving scientists and clinicians an understanding of neurologic disease. I mean, the new imaging that we have is really outstanding. So we have adaptive optics and Icahn, and adaptive optics technology is the same technology that NASA uses to reduce aberration when they look at the distant stars. Now we can actually look at red blood cells going through capillaries in retinal tissues in living patients. And what we're realizing is that cardiovascular disease can be very readily picked out when you start really looking at high-level ophthalmic imaging. I'm a glaucoma specialist, and we recognize that the same process that causes glaucoma damage are found in some of the neurologic conditions, such as Parkinson's disease. So trying to understand better the what's happening at the molecular level will give us a better understanding. Once we have better visual functional tests, I'm talking about better functional tests than even the Humphrey visual field or the visual field where there's subjective. Talking about some of my own research on, let's say, you know, visual evoke potentials, where patients don't even have to push a button. You're measuring EEG waves. Once these technologies, I think, are fully realized, we'll get a much better assessment of someone's neurologic score. And so vision, I think, is so critical. And I think I'll be happy to have Bonnie also weigh in. What we're seeing with COVID is that vision is so important to try to maintain the activities of daily living that are so critical for our patients, especially when they're living independently and they are isolated because of COVID, because COVID has caused us to kind of isolate ourselves. And that must be, of course, of enormous stress for our vision impaired as well as auditory impaired patients. So, Bonnie?
Yeah, Bonnie, please jump in.
Thank you. Yeah. So, you know, I first want to make a point about the cognition piece. And I think that in addition for, you know, looking into the eye for indicators of early markers of what's changing in the brain, much to Jim's point, it's also important to understand the ways in which vision impairment changes people's lives and the long-term implications that can have on brain health and cognitive decline. So I'm visually impaired myself. I have degenerative retinal disease. That's why I do this work. And so I study this, I live this. And, you know, the ways in which vision loss affects somebody's life is not only profound, but small and large ways, right? You change your social structure and your physical activity and the types of things you do. And we don't fully understand how that affects long-term health, cognitive functioning, all of those things, right? And so, Jim, thank you for raising that point. In this time of COVID, it's challenged so many people's compensatory skills and mechanisms who have vision loss and who are blind. It's turned it upside down. And to be determined what kind of impact that's going to have, not only acutely, right, that there is certainly a differential experience of COVID when you're going through it as someone with vision loss. You know, can you get to COVID testing when you don't drive and you can't access public transportation, or you're blind and social distancing is a different and more challenging barrier? To, you know, what kind of then long-term implications is this all going to have? This certainly is not a small or short event, and it's to be determined, but I think not unimportant.
Yes.
Good. Thank you very much. So, picking up on one of the points here, I understand. Let me throw out a data point. So the first thing is, anyone has a different information on this, please challenge it. But I understand that upwards of 96% of all visual impairment in the US, I assume it's similar in other developed countries around the world, is preventable. I mean, it's stunning. So what do we mean? Why is that? What do we mean by that? And is it about ageism? Is it about lack of, diagnosis? Is it that, heart disease and diabetes are real diseases? Vision loss is not a real disease. What are the array of health, culture, and I would say even political reasons that, assuming that number is more or less accurate? It's stunning to me.
So I want to raise a point. Artificial intelligence is going to help us understand more. So as Jane pointed out, the retina, which is clearly visible, may give us a sense of what's going on with the body. So did you know that AI can tell whether a retina fundus is from a man or a woman 97% of the time, as opposed to a clinician where it's really a flip of a coin, 50%. Also, our retinal exam can predict risks of stroke, risks of cardiac events better than some of the technologies that we're using currently for cardiology. So I'm going to make a prediction that once we figure out how to utilize artificial intelligence, that the retina photograph and interpretation of the retina photograph will not only be for diabetics, but everyone who comes in for a primary care evaluation will have a retina photograph, and there will be artificial intelligence which will read that person's risk of cardiac events and cardiac risk factors. We just don't have the technology figured out to make that. But when you look at the literature, the retina fundus will tell us so much about not only neurologic and cardiac, but I would say other parts of our health. Very critical.
Jim, you remember at a roundtable we did together, I don't know, about a year and a half ago, friends, colleagues from Philips were there. And they're a member of the Global Coalition on Aging, but they were there, and this is a topic that I know they're very interested in now, and we should actually make sure we pursue this. So after this momentum discussion, let's get back in touch with Philip. Jane, go ahead.
Look, James, I worry when, and look, I think what you've just said is absolutely true and perfect. But when in some countries pretty close to where I live, there's 30 million people that line up for food packages every day, they are not thinking about their vision. They're actually thinking about whether they've got enough food for their children. And so it's kind of like, it comes back to, you know, Bonnie, you made a really poignant point about equity. We are moving into an era where inequity is going to be the name of the game. How do we make sure that the poorest of the poor don't pay the highest price, which is exactly what's happening now? So, you know, I really struggle with this, you know, the innovation in technology, which we need, and how do we reach those that have never been reached when it comes to vision?
I would say, I think that's a very valid point. I would say that the only way we do that, we reach the underserved, is if we can demonstrate that early detection and early diagnosis will save money in the long run. As you know, that is the reason why I think companies will pour money into technology and get it out into the folks who need it, everyone, and provide it at low cost. Because if, let's say, heart disease can be prevented by taking a retina photograph, demonstrating by artificial intelligence, this person has a risk of a heart attack. And we have those research studies which show that these are preventable longer term costs. I think companies that make their money from trying to, you know, be profitable in healthcare will say it's a no-brainer. They have to get, so that's where I think technology can be embraced, is if we really treat patients earlier. I see that all the time in glaucoma. Glaucoma, most of glaucoma is preventable, but we have to detect glaucoma before patients lose their visual fields. Once they lose their visual field, we can give them the most expensive therapies, and we may not be able to preserve their vision.
Yeah, and Jane, those are some of the points that we are going to cover in our the Global Coalition on Aging International Vision Health Scorecard. We will measure some of these differences. And when I also know that even though you have an Australian accent, you are living in Toronto, Canada, and there's only one country that I think is near you. So, you know, I can guess which country you're talking about. Bonnie, go ahead. And then we have a couple minutes left. So let me ask each of you to give your one takeaway before we go to the audience, which will then be in person day of. But go ahead, Bonnie, your point.
So I think there's an important consideration to bridge both of those viewpoints between Jay and Jim that I want to offer. And I think there's so much to learn from that innovation in the AI and the statistical underpinnings of that approach. And can't we take that and reapply it to understand the social determinants and the contextual factors of different settings, right? You know, there are some applicability of those methodologies, right? To understand how to better reach people in different settings. I know it's a little complex and I'm not being direct here, but I think there's a power there to do that, to take that innovation and apply it in unique and different ways to reach populations, to get them to care. Now, I'm not saying necessarily for their retinas, but to figure out who's coming, who's not, how to get them to care in their unique setting, in their environment, to again take a person-centered approach, but apply the same type of innovation.
Excellent. So we've got a couple minutes left, and let's do one more round. Let me start with Jim. What's your sort of takeaway point? And I remind everyone that we will be moving right after this recorded session into the live Zoom session. Jim, go ahead. Your last
My
point.
takeaway point is, and for all of medicine, especially ophthalmology, is innovation, because we're going to have to transform how we take care of patients. At New York Eye and Ear, we have the first microsurgical robot for ophthalmology in the United States, third in the world. And what we're starting to do is envision, how can we change therapies? It has the precision of 10 microns, which is 10 times that of the best retina surgeon, because retina surgeons will have a tremor just because of their respiration. And so what we're looking at is, how can we change how we treat glaucoma? Maybe we can cannulate the optic nerve with neuroprotective agents. Maybe we can cannulate trabecular meshwork. Maybe we can actually provide for macular degeneration certain agents, not just in the vitreous cavity or subretinal, but to specific layers of the retina. So yes, I agree with Jane. When we think of technology, we think of increased costs. And yes, that's the short-term, oftentimes, downside of technology. But if we really transform how we treat diseases and how we diagnose diseases, maybe technology and innovation in the future will actually save us money. Now, there is probably going to be this period of time where there's going to be heightened costs, and we've got to figure out how we bridge that.
Well, but to your point, if there is one area, and I think we've all said it over the last 45 minutes, where spending on these kinds of health investments, both long-term innovations, but also directly for people who are in need this afternoon, has to be seen, the spending on health has to be seen as an investment, not a cost. And that kind of analysis, where we know that, particularly if we do the elements around the informal impacts, the productivity loss of a 57-year-old adult daughter who's taking care of her father because of vision loss or full deterioration, hardly even gets mentioned. And those kind of analyses, in addition to the health itself, is really part of the costs that we understand currently, and it's going to have a drag on our economic and fiscal sustainability. Bonnie, what's your takeaway?
Yeah, so I'm going to reiterate things I've already said, but my takeaway is that, this challenging time of COVID has certainly elevated a need for collaboration and innovation, and it's been, I think, trying to find hope in this difficult period. And to me, for vision and eye health, that's all about this holistic and equitable approach to that, and bringing all comers to the table to find a way to do that. At the center of that, from my very biased opinion, has to be the people, has to be patients, people with vision loss, that really person-centered approach. And a goal really has to be equitable and holistic.
So well said. Thank you. Jane, your final comment for us before we run into the questions from everyone out there at GSA.
Civil society organisations, such as those represented at this roundtable today, have a profound responsibility to reach across the aisle and partner with each other and partner with government in a true, authentic way. We talk partnerships and collaboration, but sitting around a table is not partnerships. And it's only by truly partnering and giving up something of what we have to actually make that partnership are we going to push the agenda so we do have, you know, a world of healthy older people whose vision is not only improved but maintained. It needs to fit within the rubric of the decade of healthy aging and link to, you know, the World Report on Vision as well as the Sustainable Development Goals. So, you know, I look forward to, as IFA does and GCOA and those on the call, to authentic relationships that deliver change, but rather, you know, just we can't keep talking. We've got to move into action.
Great. Well, thank you, Jane. And as you said at the beginning, one of the hallmarks of the decade of healthy aging is defining outcomes on the basis of functional ability. Mm-hmm. So it's a question of, as we age, not only being healthier, but also being active and having what we want. Whatever that desire or want is, working longer, spending time with my wife or my grandchildren, whatever it is, and having that as a goal, functional ability with respect to the decade of healthy aging. Well, thank all of you. We will now turn over to the in-person part. I mean, it's still virtual, but the in-person part of the session. We invite any of you who have been watching this in advance to join us at the actual session itself and participate fully in hopefully a continued robust Q&A session.
And you're live.
Well, hello everyone. We are delighted to be with the GSA participants live on virtual setting. And we hope all of you both learned from and enjoyed the conversation we just had over the last 45 minutes or so. We have another 20 minutes, and we encourage any of you to ask questions in the chat function, and we will attempt to answer them. I'd like now to welcome again Jane Barrett from IFA, International Federation on Aging. Thank you, Jane. Terrific to have you.
Thanks, Mike.
Great. Dr. James Tsai from New York Eye and Ear. Hopkins. Delighted to have you. So, all of you, let me just open up. We are all attempting to push vision health higher on global agendas, not only the health agenda, but economic agendas as well. And Jim, maybe I start with you, because I thought your description of how the use of AI is giving us literal insights, not only into addressing vision health earlier and better, but very interestingly, insights into broader health. I think the point you made a few minutes ago was that through the use of AI and technology, we can learn about cardiovascular health, for example. So the eye as literally the pathway into our bodies, into our soul, is sort of a great symbol, but perhaps more true than ever. Maybe you can elaborate on that a little bit, Jim. Developments last week even that.
Yeah, I've certainly talked to my internal medicine and cardiology colleagues. And, you know, what's unusual about the eye is we can actually observe vessels, retinal vessels, blood vessels. There's nowhere else in the body where you get a snapshot of what the circulatory system is like. And therefore, if we can actually harness the powers of artificial intelligence, I really believe that we're going to be able to have incredible predictive value on patients' risk for cardiovascular events as well as ophthalmological events. And I think I've heard it best recently. COVID has precipitated the embrace of AI and telemedicine, probably speeded up the time window by at least 10 years. That is, it's caused us to do things that we may not have done for at least a decade. So I do believe that there's going to be increased research in and also utilization of artificial intelligence using ophthalmology and the eye as a model for cardiovascular disease.
That's very well said, Jim. I have a few other questions, but Jane or Bonnie, any comments off of that or how that relates to the work that both of you are doing? Jane, you're positioned globally, of course, and Bonnie, you're at Johns Hopkins, one of the great public health institutes globally. Jane, do you want to jump off of that?
Yeah, look, thank you. And it's a great point that James made. You know, at the Vision Academy, of which I'm a member, which is unique in itself, you know, quite often the ophthalmologists talk about end organ damage. And so this is a real and tangible thing. I think one of the difficulties is communicating that to patients. And because we're really talking about function once again, so it's the communication to patients. I think also Dr. Will Lee at the Angiogenesis Foundation is doing some just world-class work when it comes to COVID, organ damage, eyes. So that might be something to look to as well. So I fully agree with James. The problem is, how do we best communicate it to the patients? That's what we need to be doing.
Well, and as you said as well, so articulately during the pre-recorded session, Jane, how do we also ensure a kind of equity for those not only who need it in the countries where it's more available, but everywhere around the globe to be able to truly transform the world. But this does, Bonnie, you made a point that I took away, and not only today listening again, but I recalled it 2 weeks ago when we recorded about hope and you know, great opportunity. And you're of course, others may be as well, but I know, Bonnie, you're a long time member of GSA, Dermatology Society of America. And so how do we sort of take this and continue to elevate vision health in all its parts at the GSA agenda, but that representing, you know, not only geriatrics, but aging health?
Yeah, no, thank you. That's a good setup to exactly what I was hoping to respond. I think this conversation is so appropriately placed at GSA, because I think about and talk a lot about how ophthalmology needs to get outside of ophthalmology to have the biggest impact. And I think this is an excellent example of that, right? We need to have forums and opportunities to talk about this type of advancement, to bring partners together to harness the biggest potential, right? Understanding what's going on in the retina as a marker indicator of what's going on in the rest of an individual's body or system will take team effort, right? And collaboration and new ways of thinking about things. And there's perhaps even ways we can leverage that information that we haven't even thought about yet. I'm sure, in fact, there are. And so my hope is that we start connecting in unique ways to think about that, to learn from the advances in ophthalmology, to better connect vision and eye health in a broader picture. I think that, to me, is the future, and that is my hope.
So well said. And Jim, did you want to respond to that? Or I had a question for Jane, but Jim?
No, I agree with the points made by Jane and Bonnie. I mean, in addressing equity, I think that if we are able to get, utilizing AI to get a better prediction of the risks of certain events from, let's say, a retinal photograph, we may be able to be more proactive and thereby limit some of the disparities in, let's say, access to care, because we already know that they're at risk. So that's where I see that technology can assist, because I think as a system, we oftentimes rely on, let's say, the resources of patients to get them to regular visits. But if we are able to, on an annual visit, predict the risks of conditions such as hypertension. We all know that when it's really severe hypertension, you see hypertensive retinopathy. But what about mild hypertension? I don't think that we as humans can detect that based on our fundus exam, but I do think that artificial intelligence can. And I go back to what I stated in the pre-recorded session. A fundus photograph can be, with 97% accuracy, determined to be male or female by artificial intelligence. When I talk to my retina colleagues, they have no idea how artificial intelligence does that. There's no, maybe it's some slight difference in macular pigment, they've said, but no one knows. And that is really one of the shocking advances that we're learning about artificial intelligence. It's really picking up probably features of the retina that we never knew. Now, there's something called adaptive optics technology, which we have at New York Eye and Ear. It's using the technology that's used by NASA, looking outward into the stars, to actually look inward. And so with these research findings, you can actually see red blood cells in retinal capillaries in real time in living patients. So yes, I agree with Jane, very costly, and I think what others said, but I just think that just like the first iPhone or the first smartphones were so outrageously expensive, and the first computer was so expensive, I think that as we improve our technologies, hopefully the costs will be manageable enough that it will be worth it.
Well, and everywhere many of us go around the world, we see this linkage more and more. Many of you joining us from Europe will know that the German EU presidency has digital health as their major theme. I hope they're linking that also to vision health, and that connects to the topic that the Finns 2 sessions ago had on aging. Jane, you of course do operate globally, and we are also celebrating the Decade of Healthy Aging.
Sure.
Where functional ability is a cornerstone, as a metric of healthy aging, as opposed to just the absence of disease, which had been a kind of prior notion around when we worried about communicable diseases mainly. You've talked quite a bit about that, and you mentioned it earlier. I don't know if you want to speak about the decade and the opportunities, or comment on Jim or Bonnie's points.
Sure. Look, I'll just comment on equity, just for a moment. I really do think sometimes that we need to get outside of our own skin. I live in a high-income country. We may have AI, we may not. But even in Canada, there is poverty existing, and some people won't even be able to take time off work to get to a screening, even if they can afford to have the screening. And so when we actually talk, we've actually really got to unpack, for example, what would policies look like if government supported, employed workers to go and get their eyes tested? What would that look like? So I think technology is vitally important, but it has to be an investment of the government policy. And that's part of the journey around the Decade of Healthy Aging. Ageism, long-term care, primary integrated care, and age-friendly cities and communities. Vision fits in all of those buckets. But I think, Bonnie made a really good point about partnerships and working across sectors. So it does have to go beyond the GSA. It has to actually look at insurance companies. It has to look at employers. What does a round table look like? What does policy-driven action look like when you've got multiple sectors and disciplines? And my final point, Mike, goes back to employment. So we really need to see this as a life course approach and ensure that the productivity of a nation is reflected in, the health assessments and treatments, and particularly vision.
Yeah, thank you, Jane. So well said. And I will use that also to give a little bit of a brief teaser on a project that Global Coalition on Aging is working on, which we will launch in about a week. And Jane, you'll be part of that launch. Thank you very much with collaboration. But it's an international vision health scorecard where we're going to look at about 15 countries, including the US and Canada, but others around Europe and Asia, in Africa, Middle East, what their policies and situations are. And one of the core learnings from that is precisely the need for even more collaboration, multi-stakeholder engagement, and learning globally. So couldn't agree more. Bonnie, as I take an eye on the chat session, there must be half a dozen references to an op-ed that I guess you recently had. And if I can, I'm trying to read it very quickly, but it sounds like there's some relationship not only to cardiovascular health and retina scanning, but Alzheimer's and the relationship among various parts of our biology. But maybe you can summarize the key points of this op-ed that many in the GSA community are flagging.
Just to be sure which op-ed you're referring to, the one on COVID?
It must be the one on COVID, yes.
Okay, sorry. Yeah, so I wrote an op-ed not too long ago about, as a person who is visually impaired, the unique challenges that people with vision impairment and really any type of disability face in this moment. And honestly, the elevation of inequities from a firsthand account, and how it highlighted to me, as someone who lives in multiple places at the same time, as a researcher who studies my own experience in so many ways, how there were still gaps that I didn't fully appreciate in the science and the data and the research, and how that drove gaps in policy, and how that there needs to be a better connection between the population, the stakeholders, the people with these experiences, to inform the data that then drives the policy. And it seems very urgent in this moment, but I think it is a sentiment that holds at all times, right? And when we're thinking about aging and aging well with vision loss, we can't do that work without connecting with people with those experiences. We can't ask the right questions, and much to what Jane was talking about, I think it's critical in this partnership approach. And so really that was the spirit of that article. And the idea is that there's an underpinning of social justice to all the work that we do.
Well, thank you for that. And I think I'm sure we all very much agree. One of the questions that have been coming through, or one of the points coming through in several questions, is about the relationship of vision health and elder caregiving. Of course, that also relates to the COVID challenges, where older adults are particularly at risk. But we haven't talked much about that set of linkages. Jane, I know you've been involved in that space quite a bit. We think about long-term care settings, we think about elder home care, but what are you seeing in that space, and what are some of our best practices, and where can we make advances?
Mike, we really have to see residential care as the home of the person. And I don't think we do that well enough. You know, the vision of a person, an older person in a residential care facility, should be just as important as my vision or your vision. But we don't do that. And so we've actually got to put the systems in place to assess a person's vision, on a regular basis. That's a right. It's a human right. And the rights of older people are just as important as everybody else's. So, it comes down, and COVID has just put a layer of complexity. But let's not forget, some of these systems were fairly broken and lacked investment for decades before.
Thank you. Well, we're coming to a conclusion here, and I again want to thank you, Jane, Jim, and Bonnie. But maybe each of you, one last thought that we leave our friends at GSA with on either both content and, as you said so well, Jane, ongoing collaboration. Jane, why don't I start with you?
Sure. Advocacy cannot be productive and effective without scientists and without the patient and without their family. So we have to actually do better in terms of partnership across sectors.
Thank you very much. Little bit of okay. Jim, Dr. Tsai, New York Icahn, give us your last thoughts.
So I would just say that I agree with both Jane and Bonnie. There has to be more collaboration and discussion. And I think that the more we can have this type of interdisciplinary conversation, that way the scientists and the clinicians don't go on one track, whereas the public policy folks go on another track. We're going to need to have constant communication so that the technologies don't get to be so intricate that they're just are so costly and expensive that they're only going to be available for a very small privileged few. So we're going to have to continue to have those conversations to make sure that everyone's on the same page in terms of which paths they're going to take.
So well said. Thank you. Thank you, Jim. Bonnie, your last thoughts?
Yeah, so relatedly, my hope is that as we get through this really challenging time, and much like James and Jane said, that this work, there's a highlight on all of the things that we do as researchers, as public health professionals, as advocates. There's a value, an increased value on equity and inclusion, and that we bring that to all aspects of our work, whether it's from retinal surgery to public health research.
Excellent. From a Global Coalition on Aging point of view, I would like to again thank my co-panelists, Jane Barrett, Dr. Jane Barrett from International Federation on Aging, Dr. James Tsai from New York Icahn, and Bonnielin Swenor from Johns Hopkins University, and thank all of GSA for this great opportunity to bring these important topics around vision health and aging to this community. So thanks to all, and wish everyone rest of a good afternoon and an enjoyable weekend. Thank you very much.